So yeah, just was about to say that this session is being recorded, and the recordings will be made available after we have done with this webinar. Just like all the other webinars, the other two that have taken place, those are available online, and those links have been sent to all those who registered, and it can also be found on YouTube. And we have found that even after the webinars, a lot of people requested and have been viewing those webinar recordings. So the overarching theme of this Game Changer series is basically to explore innovative ways of leveraging policy relevant data to drive AMR policy. And over the course of these 6 webinars, we have 11 truly gifted people working on AMR, and they will offer critical reflections and insights into AMR mitigation strategies from a variety of disciplines and perspectives. And the moderators also for these 6 webinars are global AMR experts, some of them, or most of them. And the topics will span from animal to human health to environmental health, the social sciences like it is today, and also the emerging fields of artificial intelligence and machine learning. Each speaker and webinar will attempt to answer 5 key questions through a multiple disciplinary lenses. Basically, where are we today in terms of AMR? Where do we need to go? How do we get there? What works and how much it is going to cost? They may not answer all the questions, but they will, through their presentations, try to address these questions. I'll just show you the running order and agenda for today. Very straightforward. After this brief introduction, I'll be inviting our moderator, and who will introduce Olivier Rubin, Professor Olivier Rubin, who will be our first speaker, with the intriguing title of "Why Should We Care About the Social Stuff?" It will be followed by a brief Q&A discussion between Will Parks, our discussant and moderator, and Professor Rubin. It will be followed by a talk by Professor Clare Chandler from London School, social research on antibiotic use, practices, structures, and networks. A brief Q&A discussion between Dr. Will Parks and Clare. And that will be followed by a good half an hour, broken up broadly into 15 minutes each, the person joined today. Q&A session, which going by the past 2 webinars, it has been very rich and interesting. And then in the end, there'll be a wrap up with some key takeaways by Dr. Will Parks. It won't be summary, it will be just key takeaways. And there will be a very brief, literally 30 seconds or 1 minute, where we'll get some participant feedback through a Zoom poll. It's a very simple 4 questions only. Just to say, we have had excellent participation and feedback. The past 2 webinars, people attended from nearly 43 countries. So we'll see how many countries join in today. But there was 43 countries. That made us feel very, very happy indeed. A bit on housekeeping. A link to the recording of today's sessions will be sent to your registered email. So no worries on that. That will be sent to you. Submit your questions only in the Zoom Q&A box. That will be directly channeled to the speakers and the moderator. And if you would really like to make a verbal intervention, raise your hand, and Dr. Will Parks will, at his discretion, invite verbal interventions also. Now, we really want to encourage chat. So please make use of the chat. You can even put questions there if you wish. But please focus only on the topic and the ongoing discussions, and try not to deviate or distract. Also, one more thing. Many people have asked this question. No, we are not offering any certificates for attending this webinar. And with that, that was the housekeeping. Our discussant and moderator for today is Will Parks, Dr. Will Parks. I will introduce you to him. So Will Parks is the representative for UNICEF in Bhutan, and is spearheading the UN country team support for COVID-19 as well, besides working like UNICEF for children and adolescents. Prior to Bhutan, he was a representative for UNICEF Iran, and before that, UNICEF's chief of field operations in Iraq in some of the most difficult times during the ISIS crisis, let's put it that way. And previous to that, he was the deputy representative of UNICEF Nepal. He also led a series of new economic policy planning and evidence-based advocacy initiatives as the chief of policy advocacy and planning in the UNICEF Pacific's multi-country offices. He specializes in economic policy, public health, communication and evaluation, and holds a PhD in public health and medical anthropology from the University of Queensland. And I'm happy to say I've been privileged to have known him since the past about 15 odd years when we were in WHO together at one time. Since we are speaking of UNICEF, one last piece of information that you'll be looking forward to, hopefully, and which is also, in a sense, linking the technical with the social. The State of the World's Children Report for 2021 will come out shortly. It focuses on mental health, and it includes work by London School of Economics, where that estimated the economic cost of mental health conditions and the annual loss in human capital arising from mental ill health among children between 0 to 19 years of age was a staggering annual $387 billion, and that goes up to $420 billion by 2040. This is the cost of inaction. With that, I'd like to hand over to Will to introduce our first speaker and kick off today's sessions. Thank you, Will. I'll be putting my video off, but I'll be listening in, of course.
Thank you so much, Satya, and a very warm welcome from myself. We have two really terrific presenters with us today, both of whom are going to be focusing on linking the technical with the social in the arena of AMR. And please note that there will be a Q&A session, as Satya outlined, at the end of the second presentation. So allow me to just encourage all of us to leave questions for both presenters in the Zoom Q&A area. So it's my honor to introduce Professor Olivier Rubin, who is a professor of global studies at Roskilde University in Denmark. Olivier is a disaster researcher from a social science perspective with expertise in the political dynamics surrounding transboundary and creeping disasters as diverse as famine, pandemics, climate change, and antimicrobial resistance. Olivier is the author of The State of Social Research on Antimicrobial Resistance and also the author of Antimicrobial Resistance as a Global Health Crisis. He's also currently co-editing a book entitled Steering Against the Superbugs, the Global Governance of Antimicrobial Resistance. So without further ado, Olivier, over to you for your 20-minute presentation entitled, Why Should We Care About the Social Stuff? Olivier.
Thanks so much, Will. Thanks for the introduction, and thanks for inviting me, Satya, and the whole consortium, RADAAR consortium. So as Will said, I only have 20 minutes, so I'm going to dig right into it. I'm just going to share my slides here. Okay. So as Will rightly said, the title of my talk is Why Should We Care About the Social Stuff? So Satya said it could be a little bit provocative, and that is why I've chosen this title. And it might come as no surprise, me being a social scientist, that I do think we should care about the social stuff. But I'm going to try to convince you or make the argument. So as you can see, I'm going to give you a bird's eye perspective of the health sciences and the social sciences and the tension between the two sciences. And then I'm going to dig into social science and AMR specifically, and end by talking a little bit about advocacy, because I think that's a very important issue, social issue mainly. Okay. Let me just see. Okay, so the first thing to realize when we talk about linking the technical, which I interpret as health sciences, and the social, which I interpret as the social sciences, is we have to acknowledge that there are some tensions between these two paradigms, right? So it's like a good marriage. You have to work for it in order to make it function. It's not always easy. So you can see the illustration is oil and water, and that might be a little bit out of place because I don't think it's that bad, but it could seem like it when you first start to work and try to work interparadigmic. And some of the reasons, there are many differences between health sciences and social sciences, and there are also a lot of commonalities. But I think at least 3 differences make it a little bit difficult to integrate it. At least it's not straightforward. And let me just say that these are stylized representation, right? Stylized representations. So I'm talking about the epistemological community. I'm just not talking about any individual researchers, because of course there's a great deal of variation both within the social sciences and health sciences, right? But if you sort of from a bird's eye perspective, health sciences are usually focused very much on solutions. That's in their DNA. That's something they want to comment. I mean, if you could imagine going to your physician and she's just describing everything that's wrong with you without providing any sort of remedy or any solutions to the problems, you would, I think, find another doctor or another physician, right? So it is in the whole gist of the health science discipline to come up with solutions to problems. It's not so clear with the social science. Actually, often we'll be focused on the problems themselves. Try to make sense of the problem, identifying, characterizing, criticizing, problematizing the challenges that we face. And it's not that we can't come up with solutions, but it's not sort of, it doesn't come natural for us. If we take an example, for instance, anti-vaxxers, anti-vaccination, you can have an anthropologist that tries to sort of illuminate what are the reasons behind people's hesitance to get vaccinated, why do they behave as they do, but it's not necessary that they come up with clear-cut recommendations and solutions. Often it will be enough for them just to map these complexities. So this is something we need to overcome. We need to move a little bit towards the health sciences and be more focused on solutions. But of course, the health sciences also need to recognize the value of really sort of trying to get a grips with the challenges and trying to describe them from different perspectives using different analytical frameworks or different levels of analyses. And that sort of spills into the second thing I want to say that could be a tension between health sciences and social sciences, is that social complexity is often recognized as a hindrance to implement initiatives or policies that you know will work, right? So it's a nuisance, right? It's something that we need to overcome to be able to give the vaccine to the right people or other sort of policies that you deem necessary. With the social science, it's more that we indulge in this social complexity. This is our field. This is endogenous to our work. So again, it's a little bit the same, but slightly different in that than the previous point, in that social complexity is not necessarily something that we see as external to our field, something to overcome. It pretty much constitutes our field. And so the last one is that health scientists are often or the health experts are very often or highly specialized. And by that I mean they have very long education, and you have a lot of knowledge, so there's a lot of authority in the health sciences that you don't find to the same extent with the social sciences, because our expertise is much more elusive and intangible. And often, from my experience, I've worked with health emergencies for the last 5 years, and I think I've met my fair share of health experts and health practitioners. Sometimes as a social scientist, you feel a little bit like Ross in Friends. I don't know if you know the sitcom, but Ross, he has a PhD in paleontology, his character, and he keeps introducing himself as Dr. Geller. And then when he comes to the hospital, his girlfriend, he tells him, Ross, please, this is a hospital, okay? That actually means something here, right? So, and that could be the sort of same sort of attitude you're faced with as a social scientist sometimes in these transparadigmic corporations, where your expertise is not taken as seriously as the other health experts. And of course, there is an asymmetry in this. And that can best be illustrated by this social scientist surgeon dilemma. I don't know if you've heard about it, but the dilemma goes like this. What would you rather? Would you rather be operated on by a political scientist or be informed of political issue by a surgeon, right? And I know what I'm going to choose. And that is because there is this one-way causality. It's easier for medical sciences and other sciences indeed to encroach on social sciences the field of social science, because everybody can say something about politics, everybody can say something about sociology. And I think that's fine, but we also need to be aware that a lot of the strength of social science is not just being able to say something, it's being able to develop theories, proven theories that work, conceptual frameworks, ask critical questions. And a lot of social sciences, myself included, we have some expertise for doing this for 20, in my case, but in others 30, 40 years, that cannot just be replicated by health sciences. And one of the things we can do, and that's why I put comparative is here, is that we can compare different you can say issues or themes across different fields using social science tool. For instance, my own background, as Will also told you, is in crisis management. So I've dealt with a lot of other disasters other than health emergencies. So I can try to bring some of, for instance, crisis management literature, disaster research literature into, for instance, a health emergency. The theme of health emergencies, and in that way try to sort of illuminate the field even more. But these tensions make it a little bit difficult to link the two disciplines. You have to work to make it happen. And why is it then worth it? Well, I've never tasted this peanut butter and jelly kind of thing. It doesn't look too nice for me, but I've been told that this is a sort of a symbol that things can be better when they're put together than in the individual parts. And that's, of course, what is in the synergetic kind of concept. But I would argue that it's more than that. So first of all, of course, AMR is a biomedical problem for sure, that this is first and foremost. But of course, it also interacts with social issues and dilemmas, right? And so treating it only as a biomedical problem in whatever perspective you apply to it would not be sufficient, in my opinion. And some of the benefits of including social science is not only synergy, because we've heard a lot about synergy and the benefits, of course, of synergy and interdisciplinary work and all that. But interdisciplinary work can also be within paradigms, right? So I could say I'm conducting interdisciplinary work because I'm working together with an anthropologist, sociologist, and a political scientist. That is interdisciplinary, but it's not inter or trans-paradigmic, right? There is a difference between that. And when you cross paradigms, I think it's more than just synergies. I think you sort of will discover that you will be asking other questions. You will receive other ways of thinking. You'll be subject to other ways of analyzing methods that are very far removed from your own comfort zone, but which also would allow you to think out of the box. So it's actually more than synergy, in my opinion. One of the most important things, I think, when you interact with other disciplines is that you don't need to understand the other disciplines in detail, but you need to respect the other disciplines and appreciate the values and the contributions that they can make. So it's not that, you have to sort of be familiar with all the details of medical science or indeed social science, but you just have to appreciate the value that they can bring to the table. And of course, I think COVID-19, for all its terribleness, has actually sort of illuminated some of these gains more obvious to academics and practitioners alike, that you need often to include some kind of social issues to medical health emergencies or public health emergencies, right? Now, it's very important to stress what I'm arguing here is not like 50-50 if we have to put percentages on, but it's just that you need to have some kind of component that looks at the social. It's very hard to fathom any issues relating to AMR or indeed COVID-19, where it would be where a social science, whatever social science discipline you might choose, would not have something or some inputs or some value to say. So as I was saying, I ventured into this field five-ish years ago, I think. And you know, when you go into a new field, you always, when you scout the field, scout the literature, you always look for things in the first step, you look for things that are familiar to you, concepts you know, approaches you know, and theories you know. And when I tried to venture into the AMR field, I was sort of surprised that I couldn't really find a lot that I was familiar with. And that made me question, so what is the state of social science in AMR, in the AMR field? And together with some co-authors, we tried to do a bibliometric analysis, or an analysis of the field, trying to map the field to see what is out there at all. And of course, we have some fairly, this being a bibliometric analysis, we have some sort of fairly complicated network analysis graphs and so on. But what I want to show you here is a very simple graph instead. That shows more the quantity of social science research. So on the y-axis, this contribution ratio is the ratio of science versus social science. So a ratio of 0.5 would mean that for every 2 articles, these are academic articles, I should stress, that for every 2 academic articles that have been published in science magazines or science articles, then 1 article will be published in social science, right? And I've tried to compare the field of AMR with other health emergencies such as HIV/AIDS, Ebola, and malaria, and so on, but also climate change. I put climate change in there also just for comparison. And what we see is, of course, not very sort of comforting for a social scientist trying to work in the field of AMR, because that's the green line. It's very, very minuscule what has been produced of social scientists with regards to the AMR threat. And it's sort of a bigger problem because AMR is so obviously a problem that needs social science inputs, both on the global level and the meso level and the local level, right? Because you have these different levels. So that was sort of a big surprise for me, that you simply didn't find a lot of social science research. And the research that was there was mainly at the individual level. So it was mainly, but not exclusively, but it was mainly sort of, you could say it was mainly a medical anthropology, right? So it was illuminating individual patient behaviors with respect to AMR, patient-doctor relationships with respect to AMR, even on some occasions, organizational management in hospitals and so on, right? And not a lot of social science research had been published on the meso or macro level, global level even. And the research that had been published was mainly published by medical professionals, or that, as I alluded to before, that ventured out and said something about it could be a global governance regime, should it be binding agreements, non-binding agreements, and so on. And that is what I've tried to illustrate with the picture here, that this will provide you a sort of very clear picture of the problem, but the remaining issues, social science issue of the problem, remain sort of gray and a little bit blurred, right? And so what I'm arguing is that we need to have more social sciences that influence not only medical anthropology, although that's very important, but also that illuminate some of the other more gray areas, specifically at the global level and national level. So if you go to just very quickly, sort of just to say how you would frame AMR as a global issue. As Will said, I'm a sort of professional in global studies, so my natural inclination is to go global and look at it as a global issue. There are the sort of 4 interesting prisms you can look at AMR through, social science prisms, that makes it a challenge to address as a global issue. One is, of course, that it's a transboundary threat or challenge. And transboundary doesn't only mean that, of course, you've heard this a lot, that bacteria knows borders and so on. But it's also that the solution needs to be transboundary, right? It's not enough. You can't solve it by just having national legislation or local legislation or even regional. I mean, it has to be global at some point. Transboundary also refers to not only national borders, but also sectoral borders, right? One Health approach is sort of also included in transboundary, that you need to have different sectors involved. It's also a collective action problem, right? And I mean, that is fairly obvious. I mean, nations can free ride if other nations, they really address AMR and so on, other nations would benefit even if they haven't sort of participated in that. And there's, of course, the problem of Hardin's tragedy of the commons, where you have this common resource, in this case, antibiotics, but where the cost of using that are not borne by you, but are borne by the whole society. And that means that, you have to coordinate because it's not rational for you, or it's more rational for you to use more than is optimal from a social perspective, from a community perspective. So this is a collective action problem. A creeping problem is that, of course, it's very difficult. It sort of creeps under the radar of most politicians. It's not something that is spatially or even temporarily sort of fixed in time. It has implications that are somewhat elusive and not very easy to see, and that makes it, for politicians, not a very sort of, it doesn't make it an issue with a lot of votes or an issue that really needs attention right away. Crisis of modernity. Let's not forget that AMR is a symptom of medical progress, right? It's a symptom of that we have antibiotic and use antibiotics, right? But that also makes it difficult to completely sort of solve the problem, because it's so linked to progression and modernity. And I think this last one, that it's also a crisis of distributive justice, right? Because low middle income countries, they might have many other health challenges that are more prominent for them or more serious for them than AMR, and the agenda is mostly driven by high income countries. So just 2 minutes in the end here, I think it's important to talk a little bit about advocacy, right? Because that pertains a little bit to the technical and the social, because often it's framed as this, if we just had the ability to distribute our findings, increase awareness, that would solve the problem. So this is still in the technical realm of thinking of things. The scientific knowledge is so important. If only we could make the politicians understand, they would actually do something about it. But here it's important, I think, to also include the social stuff, which is advocacy, awareness, because social scientists, they understand as a right that the world is awash with a lot of good solutions or a lot of problems that you could focus your time on, but there's resources, and time is a finite resource, right? So in my review, the challenge is not so much popularizing scientific knowledge, but to mobilize and to build networks and so on. And that's why I'm skipping a little bit fast, because I can see Will is eager to get in here. But that's why advocacy projects such as RADAAR, or indeed REACT, which is a network, an old network, 15-year-old network, are really important, but they're insufficient, right? So my proposal, which we could discuss a little bit, is to try to have the equivalent to a One Health approach, which is a technical, very important term, but it's a technical approach, but tailored to agenda setting. So what is it we need to set the agenda? It's not just awareness, it's trying to build coalitions outside the medical community, because right now, the medical community is driving the agenda forward, and also sort of defining the agenda, framing AMR as a health issue. But I think in order to really get our footing in like climate change, for instance, would be a good comparison, to get our footing in the sort of global political agenda, we need to sort of begin to build bridges to other you can say, the public, to other NGOs, to lobbyists that are much more flexible and much more knowledgeable about how to actually put issues on the political agenda, because that's not the forte of health expert, I would argue. And this is the last slide. And just one more second. Thanks for your attention, of course. And if you're interested in some of the work that we've done in together with a few colleagues, it's a very, very small team. We have 3 or 4. Do visit the website. It's not sort of totally up to date, but we have a lot of the publications that we've published on AMR on there. So I hope you'll visit it, and feel free to email me, of course, also.
Thank you so much, Olivier. No problem. Very, very rich presentation, and for sharing your thoughts. Thank you so much. Maybe just one question to this point, and then I can perhaps come back to both yourself and Claire at the end of Claire's presentation with a second question. So my question to you is really about the scope of global governance of AMR. So do you think we should try to build a global governance regime based on binding obligations? And I know that in the research, quite a few researchers are suggesting that.
Yeah.
Or should we carry on with the current kind of softer legal regime based primarily on guidelines and non-binding agreements? I'm sure some of the audience, if not all of the audience, would be really interested in your thoughts about that question.
Yeah. Thanks. Well, yes. So there is a debate in the global governance literature between these, you can say, a hard international law, which would be binding obligations in AMR. So there are a lot of problems with binding obligations. Of course, the first and foremost is that it's very difficult to monitor and actually to punish deflectors, right? I mean, the international system is not one. We saw from climate change agreements, the Kyoto Protocol, which had these binding agreements, that is not very. It's very difficult to keep countries to the promises that they make. So you can say the Kyoto Protocol was not as unequivocal a success. So there are other success stories. There is one in health, that's a tobacco framework convention on tobacco use or something like that, which was much more successful in curbing tobacco use. But I mean, so the problem of tobacco is a little bit different, because it's an international, tobacco use is an international problem, but it's not a transboundary problem, meaning that, unless I'm very, very close to the border, it doesn't matter whether, the population of Canada smokes for the health of the population in India, for instance, right? Right. There's not this transboundary mechanism with tobacco smoking. So you can have very strict regulation in one country, and actually, you're not affected by others that smoke unless they puff the cigarette smoke over the border, which is very difficult. And there's, of course, also the Montreal Protocol of ozone layer, the CFC gases, that was also very successful. But again, that was, you had this very easy to substitute CFC gases with other gases. It wasn't very expensive, and so on. So there's not a lot of evidence for the success of binding agreements. So I think we are left with some sort of non-binding agreement. But it's very important that this juxtaposition between binding and non-binding does not need to be as rigid as it. So there can be a lot of different forms of non-binding agreements. The current one we have now is where the WHO has produced these guidelines, a global action plan with guidelines and so on. But so it's still top-driven, because it's produced. I know it's a consultative process and so on, but if you go in, it's mainly been championed by a few states in the north. So it's top-driven, but still non-binding, right? So what you could, but I don't have a lot of time, but what you could talk about might maybe polycentric governance, there's a term, or localization, where you still have these non-binding agreement, but there's more buy-in from the nation, especially low and middle income countries, because the problem is, as you all know, is that the lack of implementation of the national action plans that have been produced. So they look fine on paper, but they haven't really been been implemented. And part of that could be because it's a top-driven process. And, you know, just finishing the point with AMR, if you look at it in compared to climate change, AMR is much more complex because you can have a lot of different solutions to AMR. It's not just about lowering CO2 emissions. It's about hygiene in some countries. It could be about the agricultural sector in other countries, sanitation, and so vaccines and so on. So it really needs, I think, to have non-binding, but more buy-in. So it means to be, instead of top-down driven, more bottom-up driven. But that's a short answer.
Thanks so much, Olivier. And I'm sure colleagues on the call and after this particular webinar will come back to this issue of governance. And if you allow me, after Claire's presentation, maybe I can come back to the two of you with one or two other questions and then open it up to everyone else on the call. So it's now my honor to introduce Dr. Clare Chandler from the London School of Hygiene and Tropical Medicine.
Hello, everyone. Very nice to be here. Thank you so much to Satya and the team for inviting me in to speak as part of this exciting series. My name is Clare Chandler. I'm a medical anthropologist, as Will was just saying, and I'm from the London School of Hygiene and Tropical Medicine, where I'm the co-director of the Antimicrobial Resistance Centre there. And I'm going to talk about antibiotic use today. Thanks. Okay, so I'm going to talk about a little bit about social research on antibiotic use, and I'm delighted Olivier has done an amazing introduction going over the difference between social research approaches and biomedical research approaches and so on. So I don't have to go into great detail there, but I'll just introduce some of the work that that we've been doing and sort of thinking about, and it's really following on nicely from how Olivier introduced this. And then I'm going to talk a bit about this framework that we developed from reviewing research that was done on antibiotic use in particular. Some research, you know, from across social science. We were particularly looking at what recommendations people were making for how to reduce antibiotic use. And then very briefly thinking about how do we integrate these kinds of social science insights. And then I will just go through a couple of slides, which, you know, we can make available at the end with some links for other places that you can find out more if you wanted to learn more about these approaches. So first of all, onto the social research. So as Olivier was saying, there is really quite a lot of social research on antibiotic use, but it's very dispersed and it's far less than anything else that's written on antibiotic on AMR. So the social research is kind of crowded out, but actually there is a really growing field of social research that is relevant to AMR. Some of it's directly about AMR and some of it is about issues like microbes and borders and other issues that are highly relevant to AMR, but may be hidden from view by those who are thinking about antimicrobial resistance. And I've put in inverted commas here, social scientists, because actually the people who are looking within sort of similar paradigms, to borrow over what Olivier was saying, include a whole range of different disciplines. So it's not just sort of anthropologists, sociologists, political scientists, but also geographers, historians, legal scholars, economists. So there's a whole range, and more than I've listed here. Apologies if you are one of the people I haven't listed. So we have a lot of different expertise that can be brought in to the challenges involved in antimicrobial resistance. We have put together some of these people on a website that we called antimicrobialsinsociety.org. So I do encourage you, if you're looking for people who might be doing research relevant to your area, or if you want to be on the website, if you're a social researcher, it's a useful place to kind of find people who may not immediately be visible through other routes. Just zooming in briefly to talk about the anthropology of antibiotic use in particular. So obviously we know antimicrobial resistance is a much bigger problem than just antibiotic use. But actually a lot of the funding, which is what dictates what research is out there, a lot of the funding has been targeted at understanding this phenomenon of rising antibiotic use globally. So in some places we do actually see a fall in antibiotic use with some efforts, for example, in some Some areas of antibiotic use in the UK, we've seen it reduce, but globally, this is an increasing, it's a phenomenon of increasing use. So we've been looking at it within our team from an anthropological lens. And as Olivier said, medical anthropology is often thought from the outside as being a discipline where we're only focusing on, the very, that moment of antibiotic use, and we can really see that clearly. But actually, a lot of the work that anthropologists do are trying to interpret what's happening on multiple levels. And so I think a lot of what I will say will resonate with how Olivier was building up these levels that he called meso and macro as well. The cornerstone of anthropology work is what we call ethnography, which means immersive observation. It means trying to understand what it's like to be in a different situation, in the particular situation that you're studying, and to see what makes sense there, and to understand why it is that this makes sense now that I'm in this scenario. And that doesn't just mean going to different communities around the world as we used to imagine it, but it also means that in meeting rooms in Geneva, what makes sense here? It means in the London School of Hygiene and Tropical Medicine, what makes sense here? What is automatic that we do that we don't even think about? And what we try to do as anthropologists is make that more visible than it often is. Try to bring to the fore some of the things that we take for granted as part of the ways of doing things. That's just the way that we do it. We want to make that clear why it is that we do think that that becomes normal, so that we can then be able to throw into the air those different ways of working, ways of thinking, and those patterns that we've got into the habits of, and say, well, which of these do we actually want to keep? And I think that's been a really, really useful contribution in a lot of different medical arenas, including this particular problem of antimicrobial resistance. And how we do that is not just spending time kind of doing in-depth observation, but also immersing ourselves in the kinds of documentary materials that are produced in different archives, looking at different media, policies and so on. And we also don't just do qualitative research, we also use surveys, for example, to gather information. One thing I would say is that we use surveys to find out sort of factual information to try and count things. We do not use surveys typically to find out attitudes, which are much better understood. How people think about things is much better understood through other means, particularly extended observation, because it's not really a reliable thing to ask someone, what's your attitude to this? It's not very easy for people to be able to reply to that and to give you a reliable answer, particularly as we all change our attitudes quite quickly. Furthermore, attitudes do not necessarily map onto what people do. So we are much more interested in what people are doing and then the wider reasons that people are doing what they're doing. And we also do get involved in interventions. So we've been involved in quite a few. So the anthropologists in our team, we're about 30 people. We've got 8 PhD students, for example, working in these different countries around the world. And we have been studying various different dimensions of AMR, including antibiotic use. And so this is to repeat again about the ethnography. We're trying to do ethnography of practice, also trying to do ethnography of the connections, making visible the nature of relations, not just relationships between people, but the relationships between the things that are on the shelf in this picture and global supply chains, for example. How do those things end up being the automatic things that get put on that shelf and not something else? For example, what are all of the levers and the different chains and so on that make that happen? We're also really interested in looking at discourses, the way that things are talked about. So looking at metaphors, when we talk about antibiotics, the ways that, for example, antibiotics have been talked about as sweets, I'll come on to in a moment, these metaphors, these borrowing in of ideas from somewhere else do work. They have, they make us think in particular ways. This is just to flag one of the things that we've been doing, and I know this is in common with other people who use this kind of method of, for example, antibiotic libraries. So you might bring a book of different antibiotics so that people can flick through and say, yes, I've used these ones. We've been bringing a drug bag, an actual bag of antibiotics that we've collected from different local sources around to ask residents, going household to household, which antibiotics are you familiar with, which ones are you using frequently, and we can then get some quantitative data and then open up conversations qualitatively without having to ask people, do you use antibiotics? The word antibiotic means so many different things in different places. It's not a very reliable thing to ask, do you use an antibiotic, or even do you use amoxicillin? People don't necessarily share the same idea as the person who's interviewing them. So we prefer this way of showing them an actual packet which has the label on it and talking about whether that's the one that they've used. And we found that to be really productive also for learning stories about how people use these medicines. So this is following antibiotics. We follow antibiotics, the way that people use them. We've been looking at how they're used, for example, by sex workers, how they're being used in different contexts, how they're being used by in farming and so on. I'll come back to that. We also follow the programs. So if you look from left to right, you'll see this kind of evolution in how we are thinking about antibiotics and the kinds of promotional material that people might come across in everyday life. So this is from the middle of the 20th century, and this is an advert for antibiotic candettes, give immediate soothing relief. So this is sweets that have antibiotic functions. They have not just one, but two safe, proven antibiotics to kill many irritation-causing throat germs. So this was highly promoted to people to use antibiotics as a way to soothe their sore throats in Europe and in America. We also see then a couple of decades later the essential drugs program being rolled out, in which we're trying to get medicines, including antibiotics, to people. So there was the big push of saying, look, it's not, access to medicines is very differential around the world. We need to get these medicines out to people. And then what we see when we start this concern with AMR is this shift towards, oh gosh, stop using antibiotics like sweets. So here, this picture is trying to promote the idea that we need to stop people from just using antibiotics willy-nilly, just going out and using an antibiotic just because, well, the implication is you're using it like a sweet. It's in many settings, this is not the case. People don't use antibiotics like sweets because they can't get hold of antibiotics. They're still in this situation where we're not being able to get the essential medicines to people. But also the fact that people are using antibiotics like sweets, apparently in some settings, is not a million miles away from what they were indeed being promoted to do quite some time ago. But we tend to forget sometimes this history, and what can end up happening is that we end up through some of our marketing campaigns where we're very narrowly concerned about saving antibiotics, is that we end up, using sort of slightly pejorative terms around why people are using antibiotics. In our research, and I know this isn't the same for all settings, but in the research that we've been doing, we haven't found anybody who has been using antibiotics like sweets. People use them much more cautiously than that in the places where we've been working. And then you can see that we then move on to kind of saying we need to fight AMR, save medicines for our children. And now this is true. All of these have been ways to try and help people. But one thing that I would, say that from our analysis, it promotes this question of, are we wanting to protect people or to protect medicines? And we started out with the rational drug use programs, wanting to rationalize drug use in line with making it cost effective and making it safe. With antimicrobial resistance added on top, we're now shifting the way that we use the word stewardship. A warning I would put out is that, let's be careful not to shift our entire kind of effort towards just saving the medicines, the reason we're saving medicines is still for the same end, which is to protect people and to provide the best quality care. And sometimes I worry that when we ask, to do behavior change and to narrow down our, people's expectations so that they shouldn't get antibiotics and that they shouldn't be taking them, all the time, we then end up not protecting the patients. We sometimes end up protecting the medicines as the primary goal. We need to just be really careful that we're not doing that. And we also follow the science and the policy object of AMR. So we can see that antimicrobial resistance has successfully, I would say, become stabilized as a political object, which you can see in part because it was made into an economic issue, and also because it was made into a global security issue, in addition to the health issue that we knew it was before. So as Olivier was saying, that doing social analysis of the ways that policy is formed is incredibly important. It helps us to realize how we are gaining traction with certain issues like AMR, but by labeling it an economic and a security issue, it focuses our minds on particular things that will address the security angle, for example, of antimicrobial resistance, which may cause us to focus more on spread and may cause us more to do certain things like extract information from some places to put on a global platform so that we can check whether AMR is moving around the world. That's quite different to addressing it as a health issue. So we do need to be really careful about the ways that we are framing the problem in terms of the kinds of things that we end up thinking of as being the solution. Something that we've also been looking at, and Olivier was saying, how important it is for, to respect the way that social scientists can theorize around topics. By looking at the way that we use antibiotics today, we can see that they are being used in lots and lots of different places. And I would argue that having antimicrobial resistance rising on the agenda politically, and for many of us being pulled into it because there's been funding available to look at it in lots of different places, it presents what I would call a moment of inversion where antibiotics become rendered visible. We suddenly realize that they're in all these different places. And I would argue that we can understand antibiotics as part of our infrastructure globally, that they are themselves part of social technical networks. So when we study antibiotic use in this is some of the studies that we've been doing, antibiotic use in oranges in Thailand, antibiotic use in urban informal settlements in Uganda, in rural areas in Uganda, in different healthcare settings, with chickens, with pigs, antibiotic use in replacement for better hygiene. We see the way that antibiotics have become infrastructural such that you cannot simply remove them, ask people to stop using them, because you pull down a whole set of other things that these antibiotics are propping up. We did a small project to try and see whether the research findings that we were finding were resonating with what other people were looking at, and to find out what other social scientists were recommending on antibiotic use. How do we actually change this? What recommendations are people making? We published a report, and this week an article, so you can read about this in more detail in Journal of Antimicrobial Chemotherapy, AMR. So this paper introduces this framework that we can use to see how social scientists are contributing to thinking about how we can change antibiotic use. And just to put some acknowledgements on the people who were involved in that, it's a long list of social scientists from different backgrounds, and also I'm going to show you a couple of pictures which were made by these guys to help us to think about this. And also this particular research was funded by primarily the Economic and Social Research Council, led part of the AMR Tackling Antimicrobial Resistance call. So just to introduce this framework, so we found that the majority, exactly as Olivier said, the majority of research was done in the practices arena, which is really important. Here's a picture to describe some of the different challenges that social scientists have put forward in terms of things that we might look at to address why this question of should I be prescribing or should I be taking in antibiotics, and you're doing it because of people having to queue and you're not sure if you're going to see them again, because of laboratories being closed. You've got people coming in and giving you incentives, but at the same time you've got people campaigning to save the antibiotics. So you're in this kind of dilemma at the center of these practices. I'm going to just quickly go to the next part of this framework is about structures. This is where we found that there's an increasing amount of social research that is pointing to the fact that the reason that we're using antibiotics isn't just because of somebody trying to make a decision and having all of these influences around them, but actually that there's much wider, more infrastructural reasons that we end up using antibiotics. And we got this picture drawn out because we were trying to demonstrate the fact that antibiotics end up propping up our systems. And while we've still got such poor hygiene and really, inadequate health infrastructure in many places, and we've not got the capacity to do really good patient care, antibiotics at the moment are propping that up. We need to be really aware of that before we push messages to just stop using them. They also, enable productivity. People who, in settings where we're asking people to do day wage labour, they can't take time off. Antibiotic use ends up being a quick fix for that. And it's also being a quick fix on a larger scale when we use antibiotics to solve things like poverty, when we're asking young, children under 5 to take them routinely. This is kind of a quick fix for a much more structural problem. And finally, networks. This is a kind of a much smaller group of research that is growing, which is pointing out the fact that antibiotics are not just being used with humans at the center making those decisions. They're actually emergent of networks that are requiring antibiotics or are putting antibiotics there. The kinds of metrics that we produce, the kinds of algorithms of care, weave antibiotics into our daily lives without us even realizing it. It's not a human agency problem. It's actually there in our mundane infrastructure and networks. And this may well be one of the key places that we could make the largest impact without actually asking anybody to change any behavior. This would be to change the ways that we are doing things and are setting up our whole infrastructure. And this probably is easier than trying to fix some of the structural things, although that does need to be done. It's a longer term plan and is very political. So that I think that we need to be integrating this into programs in different countries, rather than just having social scientists from universities doing this. I think we need to be trying to improve the capacity for people to do that within AMR programs within countries. And there is lots of information on the Antimicrobials in Society website. For example, this has got lots of different antibiotic use papers summarized. There's lots of webinars from lots of experts about this topic. We have a tracker of different literature, lots of different information about different literature on the website. And there's also a wider network, the International Network for AMR Social Science, which is a network of different groups of social scientists, which you might want to watch out for. And I will end it there. Yeah.
Claire, thanks so much. I wondered maybe you could put up your slides again, and perhaps if we could take a quick look at the 3 that focus on your recommendations for the practices, the structures, and the networks, because one of the questions I wanted to ask you was, in what ways can social science research inform country activity on antimicrobial resistance? And I think your 3 slides that just highlight the interventions for practice and structures and networks would be really valuable for those who are listening in. So if that's okay, just ask you to go through the practices one.
Yeah, so the practices one, this is where you've got your, prescribers and patients right in the center of your thinking. And here you're then talking about trying to change people's behavior. That's your kind of imagining that antibiotic use is a product of what people are doing in that moment. And so you can do things like changing the remuneration arrangements, enhancing healthcare accessibility so that people are able to come back into healthcare settings that you don't have to prescribe straight away, improving the communication, and this includes critically giving people information this is care, giving people information about the duration, for example, that their cough is likely to last. So giving people information about their illness and why they don't need to have antibiotics in the cases where they don't. Providing information on medicines. So this is to say when you should and shouldn't use medicines. And this is something we're looking at the feasibility of at the moment. So in terms of, letting farmers know actually when you should and shouldn't use antibiotics, rather than just telling them to never use antibiotics, quite unrealistic. So providing accurate information. This requires us to challenge some of the medical enclaving of knowledge. It requires people with these expertise to share information rather than to keep information to themselves. So that actually is quite a shift in the way that medics have been told that they're supposed to behave. But I think that, collectively these things are possible. The size of impact that it can have, though, is still relatively small, because the margins that you can change really when you're thinking about some of the other issues like these issues, you've really got to start also looking at, the structural issues like these, which, in terms of hygiene, having to ensure that we've got much better hygiene so that we're not having to use antibiotics, sanitation systems, water systems, so that we're not having to use antibiotics to quick fix those. Improved working conditions in terms of, and working conditions in terms of being able to have sick leave, social safety nets, being able to, and safety nets, for example, for farmers, so that, they're not having to continuously use antibiotics to prevent a massive loss. So I think this, those are quite big issues. Reducing inequality, it's not something that's going to happen overnight, and it's not something that somebody on an AMR committee can really do an enormous amount about. Which is why I think we tend to focus on those narrow interventions, but of course it has much more potential for impact. And then with the networks, we have, the ability, I think, to make quite a big change, but we have to think quite differently to be able to look at this. We're no longer putting people's human agency at the centre. Here, we're trying to say that there are, other things like the way that we collect data, the way that we design algorithms. I mean, it's fascinating. We did an analysis of algorithms of care that tell people how they should care for patients. And essentially, the bottom line for all of those tends to be give a medicine or don't. There isn't a box on there that says explain to the patient this and this and this. It's kind of, so you end up kind of writing into people's practice that they're going to be given medicines. So, and then there's quite a lot of issues around supply chains that gets sort of hidden away. So I think there's quite a lot that can be done there. Also in terms of the kinds of information that's given by medical representatives and the way that, a lot of supply chains are actually around incentivizing increased use. So I think those things can be looked at as more kind of material networks that then will change the conditions that people are working with, and they won't even sort of have to change their behavior. It will be changed for them.
Thank you so much, Claire. And maybe we could just bring back Olivier on his camera. Olivier, if you're able to come back online with your camera, that'd be great. As we just take a look at a few of the questions that are being asked by colleagues in the comment box here. So thank you both so much for your extraordinarily rich presentations, and several of the comments are thanking you for the richness. And perhaps we could just start with this particular question from Pirana, who asks, how do you communicate these social science findings to policymakers, and are they the main target? So maybe I could ask Claire and then Olivier to have a think about that. Claire?
Yeah, so how do we communicate with policymakers? I mean, I think I'm just putting in the chat the link to that paper. Somebody was just asking for that. In terms of communicating with policymakers, you know, these people have an incredibly difficult job. I don't see it as my job to be communicating. Like when I'm discussing with people who are trying to make policy, first of all, they are sitting and they are always balancing up this and this and this and this and this and this. And they say, you know, well, I'm being asked to promote AMR as a really important thing, but you need to give me this information and you need to give me the economic case, or you need to give me this information in order for me to be able to take that forward. So I would say it's less that I communicate with them and it's more that I take a brief from them in terms of looking at, well, what do we need to do then? What information do we need to provide for you so that you can do your job? And that's where I think, you know, that's all very well having external researchers do that. What I would really like to see is them being able to say to their AMR committees, we need this information, and the AMR committees having enough resource to be able to go off and nimbly do that kind of rapid research to create the case. I think currently the idea that we, you know, I live at the London School. I work at the London School in London, and that's not necessarily the right place to be prescribing policy interventions to somebody in Kampala.
Good point, Claire. Thank you. Olivier, same question. Thoughts about how social science research findings can best be communicated to policymakers?
Yeah, no, so I agree with Claire in that so one of the common misconceptions about social sciences, especially political scientists, I think, is that we are well equipped to communicate to politicians, that we are the missing link between health experts and politicians, and we're really not. Like I mean, if I was capable of being a politician, I would have been one. So I'm not. It's a common misunderstanding that we are better at communicating, and we're actually not. We are better at analyzing and categorizing, but communication is a very difficult discipline. It is a discipline, right? So I'm not a great communicator, and I don't have more access to politicians than others. But what I do in my research increasingly, I mean, I've been a really, really bad social scientist, not caring about implications or policy recommendations at all when I first wrote my PhD like 15 years ago, 20 years ago now. But I've increasingly tried to have a clear section on, when I've done a work, what are the implications for policy, right? And I've tried to formulate them either in a brief or in a newspaper article, and of course also in an academic article, right? So I've tried to be much more focused on actually coming up with solutions, which is difficult when you're not used to thinking like that, right? When it's not part of your field as such, like you're not being evaluated as, you know, whether you're good at solutions. So I think that's what I would say. It's not our job. I think there are others that are much better at communicating and lobbying and networking with politicians than academics in general.
Thanks, Olivier. And maybe I'll just carry on with a question that Prerana also asked, and specifically asked for your thoughts, Olivier. And Claire, please jump in if you have anything else. But the question was about funding for multidisciplinary research, and often social science research seems a little bit strange to maybe colleagues who are in the AMR field working in the health sciences. So they don't quite understand the value of bringing social science into a multidisciplinary trans-paradigmic approach. I wondered whether you can suggest any ways of breaking down these barriers to get multidisciplinary research funded.
Sure. I mean, the recent call on the JPI AMR, the Joint Program Initiative of AMR, they actually explicitly include now a sentence saying like social science, like projects that include, I don't remember the exact sentence, social science research would be preferred or something like that. And that has led to a huge sort of demand for social science research in the project. I think I was contacted by 6 different consortia sort of to come with a component. Of course, it's just a component, minor component in a larger consortium, but I think it's an important one. And of course, the trick is not to be considered a rubber stamp, right? Because when it's top driven, of course, like, okay, we need to have social scientists. Let's call this guy and give him a few funds, and then he can make this component. But I think what happened, and I have little doubt that some of these consortia thought like that. But as we then have these discussions about the project and we have all these meetings, I think that is, of course, it was during COVID, so they were sort of online, but I still think that we tore down some barriers in those meetings, and I actually got a chance to talk a little bit about what social scientists can do. I mean, I think the role for me in most of the consortia that I was involved in was originally as a communicator, as we talked about, or a facilitator of workshops. Right? That was sort of the social science role. But I think I successfully expanded the role to actually also do some analysis. So I think that's the way forward. But of course, there is a danger when it's sort of top-driven. You need to include a social scientist, that it becomes sort of something that you just do because you have to. It would be better if it grew up naturally. But I think it's difficult, exactly because what I talked about, it's so difficult organically to just grow together, because there's so many tensions in the beginning. So I think it's okay to do it top down, but in the beginning, so that's one way to do it, to say, well, you need to have a social science component in there. Yeah. And I think I think the funding agencies are increasingly being aware of that and doing that.
Great, thanks, Olivier. Claire, very quickly, from your rich experience, any solutions to breaking down these barriers to getting more social science research embedded in multidisciplinary research? And if you could just keep your answer really swift, because I can see some other really interesting questions coming in.
I actually think it's a lot better in AMR than it is in many other areas. And I think that speaks to, generationally, a change in the appetite of scientists to work together across different disciplines. So I'm quite optimistic. And I think there's also an increasing understanding that we don't just do behavior studies. There's an increasing recognition that we can do more for this problem. We can do more in our analysis. Working collaboratively with people. So I'm actually quite optimistic. I think we've got a way to go, but I do think it's getting better. And I also think, as Olivier says, funders are asking for it. I think one of the big things that we need to look at is how we do the preparatory work before we come up with these proposals, so that it's going to be relevant. So it's going to actually be useful. This is not just a scientific problem. This is not just for us to get academic publications. These are really, really important real world problems, and we need to start where people are at. And so I think the kind of a really important bit that's missing often is, working with people to learn what their problems are, so that we can try and, put the best teams together to answer those questions.
Thanks, Claire. A question to both of you. What, in your views, would be the sort of social data or information that would be most useful to collect on a routine basis by countries? Olivier?
I think it would be some kind of surveillance data but that's not only on the local level as Claire was in her presentation, but on different levels. So it's not only on the hospital level or on even patient doctor level, but also on you can say not a regional but a municipality level, a national level, and also include other actors like politicians, their knowledge about AMR, their interest in AMR, tracking that and stuff like that. So that would be useful for me. Of course, I'm a political scientist, so I might be biased in what would interest me, but that would be something I think is valuable. I think we need to scale up, and we need to scale up. I also saw a question about all the CAPS. Knowledge, attitudes, and practices, and they're of course important in their own right, but at some point we need to scale up the information.
Great. Claire, any thoughts about routine social data that you think ideally should be collected?
I think routine data is really, really helpful. I would just really advocate for that to be factual data, and there may be some key social I'm not really quite sure what social data would be, but you know, there are key data of what people do, you know, behavior data. And I think that could be useful once we know what are the key data to collect. But this is different in different settings. You know, if AMR is being driven by, you know, hygiene practices in hospitals in one place, then that's what we should collect data on. It's not going to be very helpful there to collect data on pig farming if pigs are, you know, if that's not the problem. So I think, you know, you've got to be quite judicious about being cost effective in collecting that kind of data. It's not cheap.
Absolutely. Claire, there's a question specifically for you from Adrian, who asks if you could speak to the ethics of incentivized antibiotic dispensing, especially that which is driven by large pharmaceuticals companies. It is common in veterinary practice, but we're also seeing, Adrian says, a growing problem in the human medicine. So what about the ethics of incentivized antibiotic use?
Yeah, I mean, I've just dropped in the chat actually because I wasn't sure if we'd get to the question. I completely agree, Adrian, and I think it's just we don't talk about it enough, and I'm really curious as to why that is. I imagine that this is quite an uncomfortable topic, and when we're trying to, you know, get everybody on board and around the table to address AMR, we perhaps don't want to talk about the practices that are actually driving AMR, which are from the same people that we need to be collaborating with to get to fix the pipeline of antibiotics into the future. So it's quite a tricky one, I think. But I think what we found, I was surprised, given that the literature is not, you know, particularly heavy on this. I was surprised that every setting we went to, in a study we did with the WHO, every setting we went to, people were being visited repeatedly by drug reps in these were prescribers for human and animal prescribing, and dispensing. I think there's a huge impact of medical detailers, probably advertising and so on, that we aren't capturing enough. And I think I would really recommend that people look at that country by country. Figuring out how to deal with it is a real problem, because often these people are filling the gaps that countries aren't able to fill in their health systems. But if this is the only source of information, they're telling you that this is the best antibiotic you can give to your patients and will give you 4 boxes for the price of 3. Unfortunately, that's what ends up happening. I think the framing that Adrian's used there about ethics, I think, is a really important one, to thinking that through.
Thanks, Claire. Olivia, maybe a question pertinent to your kind of research and your interests, coming from Amin, who asks, AMR really as an issue is still not as globalized as other major public health threats. Would you be able to point out the reasons for this and how we can advocate for more global awareness on AMR? Olivier?
Thanks. That's a big question. So I think that the main challenge when trying to if you want to make it more global or more on the global agenda, is that it's still very much driven by the health community. Health experts are very good at framing or understanding an issue and understanding what are the problems with the issue and communicating that. But that's the first step. So the second step is to actually make it to the political agenda. And here I think we have a problem, and it shouldn't be the health experts or indeed social science experts that should push the agenda, but a much more broader coalition of actors. You see it with climate change. Like the IPCC, they just published their report, the 6th, but it's not them that are pushing the report out. I mean, it's being pushed by the media, the social media, like thousands of NGOs, committed NGOs. Climate change is part of a political program in a lot of countries, right? In party programs, we see in Germany, the Green Party sort of doubled their mandates. But AMR is not a political issue. AMR is not even in the Sustainable Development Goals, like directly. I mean, you can always sort of see that they're relevant, whereas climate change is much more there. So I think we need a broader coalition. It's not about the science, not about pushing science, it's not about awareness, it's about networking, building to external actors that are much better at pushing issues than academics are. It shouldn't be our job, or especially not health experts. They have enough. It should be sort of generate a network of other actors, lobbyists, and so on that could influence. That's the only way if you want to do it bottom up, right? If you want to sort of really generate it. It's because at some point, you know, the interest in AMR will go down, and if there's not a foundation, if there's not a sort of interest that is broad-based, if it's only in the health community, then it might die out if other issues emerge that are more important, right? So that's the strength of climate change. Even though we had the COVID-19 pandemic, it didn't die out because it was so broadly based and so ingrained in the public and the politicians that it didn't sort of fall from the global attention. And we need to do the same with AMR. So it will take time. It's not an easy fix.
Thanks, Olivier. I'm sure Claire has some views also, but Claire, if I may just pinpoint a question that's come in from one of the audience also. It relates to the very fairly effective gatekeeping system that is available in the Netherlands in the healthcare sector, where antibiotic AMR is being curtailed to a reasonable level. So what kind of lessons can countries with AMR problems draw from this kind of example, linking up with your insights on social science?
Thanks. And again, I've just answered this one. If you're looking for it, Olivier, it's in the answered questions. I just answered this one by typing because I didn't know if we'd get to it. Because I think this is really, really interesting and important. And I don't know how easily you can put the cat back in the bag. The reason that system works is that the system has always been that. You know, the system was built in to be able to they treat medicines in a particular way, and you have this kind of it's a whole country system that medicine has to, as far as I understand, a medicine has to be completely not working. It has to be proven to be worse than something else that's coming in before it will be taken off the shelf. So it's a really, really tightly regulated system. I wonder how easily that can be, you know, added on to another system where, you know, perhaps there's been a much more liberal you know, medicines market, and as there is in most other places in the world. One area that I do wonder if there is some opportunity to learn as we move into the future is the increasing e-pharmacy area. You know, we're going to be moving inevitably to much more of an online pharmacy world. And is this a possibility to kind of get ahead of the curve, as we know that that's starting up, probably will take over at some point? How do we think about regulating that? How do we learn from examples in different countries to see if we can, you know, do that better, given that we know some of the challenges that have emerged around treating medicines as a, you know, open marketplace? Can we do something about that moving into the future? Mainly because the people who are getting incentives and gaining from the current system are in positions of power, and they're not going to want to stop gaining from the system. So you know, to supersede that with another system would be very, very difficult unless the market is driving that itself. And that's where I wonder if there might be something to look at with e-pharmacies.
Thanks so much, Claire. Maybe just one final question. There's several coming in, but perhaps there's an opportunity to answer them through the network. For Olivier, could you just explain a little bit more about how AMR you're seeing as a distributive justice crisis?
Thanks. I was actually trying to answer the question live, but I'm not so good at multitasking as Claire. So it's better to do it here. Yeah. So distributive justice, that is, you know, it can be both spatially, meaning that it's intra-generational, but it can also be between generations. And AMR is both, right? I mean, if you use a lot of AMR, not a lot of antibiotic without any concern about inventing new ones and so on, it would be a cost for the future generations. But mostly it's due to intra-generational injustice, meaning that the ones that are standing to benefit the most, it would be the high-income countries. In lower middle-income countries, it might be, you know, a health challenge among many. AMR, I mean, as as you all know, in a lot of countries, the problem is more access to antibiotics. So framing it as more as effective antibiotic stewardship would be good instead of just antimicrobial resistance. But that's what I mean, like that you know, that the costs are, and we see it often also with climate change, and who should bear the cost? Should it be the low and middle income countries, or should it be the high income countries that are driving the agenda forward? And right now, the high income countries are not really sort of, you can say, allocating enough resources to low and middle income countries if they want to have it solved, in my opinion. So that's the sort of distributional justice issue. I don't know if that was clearer, but otherwise I'll try to write it in the chat.
Yeah, if you there's another question right at the bottom of the chat. If you could both take a look at that, that'd be great. Maybe just before I pass to Satya and we wrap up, just a few thoughts from myself in terms of the key takeaways. And I can't possibly do justice to the richness of both Olivier and Claire's presentation. So I want to thank you both so much on behalf of everyone listening in. Maybe just a thought from the fact that I'm with UNICEF, and UNICEF is also very globally concerned about AMR. 40% of the deaths globally among children under 5 are caused by diseases whose treatment is and will continue to be affected by the growing threat of AMR. So prioritizing children within the AMR agenda is also really, really required to protect every child's right to health, as well as tackling this global challenge. So drug resistance is perhaps one of the greatest threats to child survival and global health from UNICEF's perspective. And it really threatens the continued progress on child health, as drugs which are needed to tackle very common childhood illnesses are becoming less and less effective. So I think it's really important that as we move forward, current policies and initiatives to tackle AMR, which rarely address the specific needs and vulnerabilities of children, we need to make sure children are at the center of the AMR agenda to protect every child's right to health. And I guess by extension, Olivier, you talked about this intergenerational distributive justice crisis, and it's really the generations yet to come who are going to be suffering because of the current AMR situation. So we've really got to correct that for now, but also for the future. If I may just end with 5 very quick takeaways from the 2 presentations by Olivier and Claire. Certainly, number 1, through the social sciences prism, AMR is a transboundary collective action problem. It's super wicked, in Olivier's words, and creeping all the time. So AMR is also a crisis of modernity, and as we just talked about, a crisis of distributive justice. The second takeaway for me is that the challenge of linking the technical with the social is not so much about popularizing scientific knowledge, but is to overcome a deficit in mobilizing sufficient numbers and kinds of powerful actors to push forward policy and its implementation. As we've learned in many, many other public health and climate change and other threats to humanity, these movements that really get people to pay attention are created by massive networks, coalitions of influencers. And I think AMR needs to move into that space of mobilizing these kind of actors rather than just relying on, though it is important, the popularization of scientific knowledge. The third takeaway, it was a question, I really like the question Claire posed in the middle of her presentation, and it immediately got my medical anthropological antennae, really flicking. Is, do we want to protect people or protect medicines? And this to me is perhaps the dilemma that is embedded within AMR research and policy. And it's a fantastic question, Claire, and deserves even a panel session just on its own, that one question. What you revealed in your presentation related to that is there's now, I think refreshingly, a very large body of social science research, and that body is moving our understanding beyond simplistic interpretations of knowledge-driven practices to understanding that there are particular configurations of the social, the economic, the political, the historical, in which antibiotic use is actually situated and is driven by. So a broader, multi-leveled understanding is where social science research can take the AMR policy and practice field. And I think that's a really important point that you also made in terms of the fourth takeaway. we need to look at interventions on several layers. And you talked about interventions that change practices, and we need to understand the context within those behaviors or those practices in which people are making decisions about antibiotic use. At the structural level, Claire talked about interventions must modify political and economic conditions to reduce the need for antibiotics to be used. And finally, from a social science research on public and global health infrastructures and architectures, you talked about redesigning networks and the tracks that define antibiotic use. And I think these are really key insights that you and Olivier have been able to give to us. And perhaps the fifth and final takeaway for me is that so many questions are arising, and our audience has posed several, the ethics of incentivized antibiotics use. Claire, you talked about e-pharmacy, a brand new area perhaps of research that needs to happen. So the future of social science research into the health sciences on AMR is extremely uncharted in many ways, even though we've got this large body of knowledge building. All I can say is that it's so encouraging to have this opportunity, and thanks to Satya for putting on these webinars to really bring all of these different disciplinary perspectives to a global health threat to everyone, and particularly to children. I want to finish there and pass over to Satya, and just finally thank Olivier and Claire once again.
Thanks, Will. I mean, this has been tremendous. You moderated beautifully despite some fluctuations with electricity. And thank you, Claire and Olivier, basically for raising the level of discussion, and also to what depths we will have to get into to, in a sense, quote, link the technical with the social. In my opinion, linking the technical with the social is important, so that whatever is being done in one domain, we should be able to see how it's influencing the other, and vice versa. I mean, otherwise, there's a global assumption that we need to reduce consumption, and that will reduce AMR. So whether that basic hypothesis holds or not is not known. We know that these are drivers, but whether it will actually stop the emergence and spread of AMR, it continuously needs to be interrogated. So I would like to really thank you for very kindly joining these webinar, and to all the participants. I would just put up that little evaluation survey right now. Jiong, it's only 4 questions, only 30 seconds, and hosts and panelists cannot vote. We would be very grateful if you could fill this up, so that this will be very useful for us going forward. And meantime, just to let you know that the webinar number 4, the next one is focused on private sector, public sector, the tensions between them. And we have got a speaker, wonderful speaker from Pfizer. We have got Catherine Moore from the GRAM project. And then it's being moderated by Gemma from the Wellcome Trust. So we really ask you to join that also if possible. And thanks to many people whose names I can see have stayed through all the 3 webinars. And all the recordings will be available online. They will all be sent to you, and they are available for you to look at. And please, also, you can pass them along to other people, because each of these webinars have been very, very valuable. So with that, I'd like to also thank the team which is behind me. I mean, there's a whole team working with the invitations, with the platform, with the being nice to Claire, Olivier, and Will, and making sure that they're happy and sending them the right notes and things like that. So I hope you enjoyed it as much as we did. And a big thanks to all the people who attended this and for all your questions. So thank you. With that, at least I would like to ask for a call to close the webinar. It has been very rich. Thank you for your time.